Hello, everyone. Thank you for joining our breakout session where we're going to share an update on NCCS project on telehealth. We conceived of this project because of the explosion in the use of telehealth during the COVID-19 pandemic. We wanted to make sure that patients' voices and perspectives were heard in the implementation of telehealth. We're grateful to Pfizer for providing funding to support this project and incredibly grateful to partner with Kristen McNiff, who worked with us last year on our Redefining Functional Status project. She's a seasoned pro in healthcare quality, formerly having worked for ASCO and as the Vice President of Patient Quality and Safety at the Dana-Farber Cancer Institute. She's now president of KM Healthcare Consulting, and we love working with her and are delighted that she could join us today to give you an update on our project that is underway. I will turn it over to you, Chris.
Thank you, Shelley. I'm so happy to be here joining you all virtually today and to speak on behalf of the NCCS team that worked on this project. So we'll talk more about who's on the team toward the end, but I'm delighted to join you. Okay, so you don't need to hear from me that we've all experienced a dramatic change in our daily lives as a nation since we recognized the COVID pandemic in March. And as you all also well know, our healthcare system has had to react in unprecedented ways and at an unprecedented pace to respond to the demands of this outbreak. And that leads to really the statement of need for this particular project, which Shelley briefly mentioned. These very, very fast regulatory, societal, and practice changes have led to a dramatic increase in the use of telemedicine. And that includes use of telemedicine for care related to cancer treatment and cancer survivorship. Because it has been so fast, there has been little opportunity for guidance from people with cancer about what is most feasible and acceptable in terms of telemedicine for cancer-related care. And we now feel like we have this narrow window of time to ensure that the patient voice is heard, understanding that there is a strong desire to maintain some of the progress that we've made via telehealth since the COVID pandemic began in March. So we want very much to have the patient voice inform what happens next as the nation begin to emerge from the COVID-19 pandemic. Now, just some quick definitions to start. First, I'll say that the terms telehealth and telemedicine are often used interchangeably. And in fact, in this presentation, I probably will use them interchangeably. The definitions really differ, not only between telemedicine and telehealth, but also depending on who the definer is. So we see them defined in different ways, but there are some examples that are provided on this slide. Generally, telehealth is considered a broader concept than telemedicine, and telemedicine is a little bit more focused on that provider-patient interactions done using some sort of electronic information or telecommunication platform. So that's really what we'll be talking about today when we talk about telehealth. And again, we may use both. I may both use the term telehealth and telemedicine during the presentation today. On this slide and the next, I just want to very quickly highlight the very complex and detailed policy and regulatory changes that we've seen since March, and an attempt by the federal government and CMS, particularly Medicare, to encourage the use of telehealth services in place of face-to-face visits while we dealt with the pandemic. So first, you will note that Medicare during the time of the public health crisis is paying physicians for telehealth services at the same rate as in-office visits. And that has certainly been a huge, important driver of the use of telehealth. Also, physicians or providers are able to either reduce or waive the cost sharing for Medicare patients associated with these types of visits. The expansion of access to telehealth for Medicare patients means that patients who are in any setting, not just rural areas, are able to receive services using telehealth. That physicians are able to provide telehealth to either new or existing Medicare patients. Interestingly, and we certainly heard about this during the project, physicians are able to and are providing telehealth services from their home, and they can provide telehealth across state lines, which has been an important change. A few other important changes are the physicians are allowed to provide telehealth visits using audio only, so telephone, it doesn't require the use of the video component. That physicians are able to work with their patients to do remote patient monitoring. And this is not limited to physicians. So there's a renewed and expanded ability for social workers, psychologists, physical therapists, and others to engage with patients using these telehealth technologies. And then the final point I'll just make on this slide relates to that last bullet, which is about greater flexibility in actually the technology platform that is being used to conduct these telehealth visits. And I do think that this, based on everything we've heard in the anecdotes, this really has enabled providers and hospitals and systems to expand their telehealth very quickly, but also has an impact on the patient experience. So during the time of the pandemic, at least while we're in this public health emergency, pretty much almost any existing platform that was developed for business and communication use are able to be used for telehealth purposes. So this includes services like FaceTime, Skype, and Zoom. There are some limited public-facing communication services like Facebook Live and TikTok, which have been called out by the Office of Civil Rights as those that are inappropriate, so should not be used for telehealth. And I think that's a little bit reassuring to hear for some of us. I know that I personally could find TikTok if I needed it, but it doesn't seem like the right type of technology platform to use for providing healthcare services. So we're not going to go into a lot of detail about what's happened out there in the marketplace in terms of use of telehealth. And the data are actually still really being compiled, especially telehealth use specific to oncology. So that's something that hopefully we'll be able to see more as we get a little bit further out from the initiation of the pandemic response. But on this slide, you can just focus on that area in the right, which has the red circle around it, for just a quick view into what's happened nationally. So this is looking, it's a Fair Health, it's a source that's available online if you'd like to check it out. But it just shows, based on analysis of claims, what's happened in terms of telehealth use. So you can see that small little tannish bar on the left is showing use in March 2019, and then the bar to the right is showing use this past March. And there has been a more than 4,000% increase in use. So clearly we've seen a significant change. And then if you look down at the bottom bar chart, it's really showing the comparison between sites of care. So urban versus rural. And you can also see that in March of this year, of 2020, that there was significant use in urban areas, which is, again, something that we just have not seen much of in the past. And I think is reflecting a lot of the hot, where the hot spots are for COVID-19 have been. Okay. So as you think about, again, we're still compiling these data. We've heard anecdotally similar trends in oncology, but hopefully in the future we'll really be able to look at that data in some detail. But it does make you wonder, with this just very dramatic increase in use, what we can expect in terms of these trends after the pandemic. How many of those policy and regulatory changes, how many of them will stay in place? We do expect, kind of the genie's out of the bottle. We've heard from many of our leaders in the federal government and within CMS. So we don't expect to go back to pre-COVID policy and regulation, but certainly expect to see some kind of tightening and maybe some changes to some of the reimbursement parity that was available during this time. So it makes us, think about what's going to happen in the future, and again, how we can ensure that we can inject the patient's voice into that conversation. And that leads us to our project today. So we have been working on the NCCS team to engage patients and survivors and providers, and I'll talk a little bit about how we're doing that, to be able to really clearly articulate patients' needs and perspectives for the most effective use of telemedicine in cancer care. And we're doing this to both inform clinical practice and public policy. And as Shelley mentioned, we are all very thankful that Pfizer has generously supported this project. This slide provides a bit more detail about the specific goals of our project. We want to work, and we have been working, as I'll tell you, to hear directly from cancer patients and survivors about what some of their experiences have been with telemedicine and how we can learn from that and how we can make sure that we're maximizing the benefits of telemedicine in the future. We want to obtain feedback from providers to either support those messages from patients or maybe offer refinements or counterpoints. And then to use those two mechanisms of information gathering to create some resources, some very actionable near-term resources. So one is a toolkit for oncology practices about how to address patient barriers and how to increase the effectiveness of those telemedicine visits. And the second is a toolkit for patients and families about how to best prepare for telemedicine visits, particularly for cancer-related care. And then we know that there will be policy recommendations that will be required to bring the patient guidance to fruition. So we also are working to develop and disseminate policy recommendations and engage in policy advocacy related to telehealth for cancer care. As I mentioned, we're really doing this in a very narrow window. We don't know what's going to happen with, over the next few months with the pandemic, but we do know that the changes in policy and regulation are beginning to come under scrutiny now, and that at least plans for what telehealth will look like in the future are being very actively discussed. So we want to move quickly, and we put a very pragmatic and very rapid study design together to support this project. First, we convened a steering committee, and Shelley and her colleagues, who just are so engaged with many of you, were able to identify a very thoughtful, very informed, and very committed steering committee very quickly. So in the matter of a few days, she identified a steering committee of patient advocates who are helping us in many ways with this project, most importantly to refine the approach and to help us in the near future to refine the findings. And maybe in terms of action, the most critical piece was to identify our diverse focus group members. So we relied on the steering committee using kind of a snowball approach to go out and to find focus group participants who could pretty quickly get on virtual focus groups with us to share their experiences and to provide recommendations as we move forward. Next, using a pretty standard qualitative focus group methodology, we created a focus group guide and tested that. Again, based on the outreach of our steering committee members, we did recruit focus group members. In fact, we had planned to have 5 focus groups, but we had such positive recruitment response that we ended up having 6. we did convene those. So we wanted to make sure that we weren't limiting the ability to hear from those who may have the most challenge in participating in telehealth by requiring a Zoom or any kind of platform like the one we're on now. So we did an audio only focus group as an option, and then we had one audio only, and then we did 5 that used video but allowed people to join using audio only if that was all they were able to do. Our smallest group had 3 participants, and our largest had 7. So that was our range. The majority of them were 5 to 7 participants per focus group. And again, this was virtual. So we're convening at for 90 minutes using a platform like this one to really engage in a very very open discussion. So I was the focus group facilitator. I used the guide to, kind of put questions out there, but we really had great dialogue among our focus group participants, and those were all recorded. So we were able to really have a wonderful, diverse representation among our focus groups. When we were working with our steering committee to identify focus group participants, we really were asking them to help us find diversity in terms of gender. Often focus groups, it's very easy to have women only, and we certainly did not only want to hear from women. In terms of gender, age, race and ethnicity, residency, so where in the country they live, and we wanted to make sure we were really targeting some of the hotspots for COVID-19 in the country. We looked for people who were in both rural and urban settings. We certainly wanted to make sure that those who live in rural and less resource settings were represented. We looked for diversity in terms of cancer diagnosis, and for those who are in active treatment versus their survivorship phase. And we were, again, our steering committee just did an amazing job in a matter of a week and a half to identify and schedule these focus groups. So we were able to really get a very rich set of individuals participating in these discussions. And so what's happening now is we're looking across the transcripts for those 6 focus groups and identifying themes. And we're doing this using standard methodology for focus group analysis to have a clear articulation of the themes that came out. We're going to just give you a sneak peek of the summary. So it's not just, you can keep in mind that this gives you a flavor for what the themes will look like and what some of the products associated with the project will say, but we, at this point, it's just a summary. We don't have the themes. So those all have check marks next to it so far, because those are either completed or underway. We will later this week review the themes with our steering committee and get any refinements from them that are needed. And then, as we mentioned briefly, we will then kind of test the themes with a panel of oncology providers. And the reason to do that is because we want to, even though our focus group members were actually incredibly aware of the pressures on providers themselves, we want to, have an ability for oncology providers to maybe reality test some of the recommendations. And if there are large barriers to being able to provide future telehealth services in accordance with the recommendations from this project, we want to hear from them what those barriers are, and if that could be part of the advocacy work that happens related to this project, if we can help them address barriers. We also know that they may have, some additional thoughts from their perspectives about how telehealth has gone for them, so we'll collect some of that information from them as well. So that'll be a way to help us to provide a complete picture in the findings of this project. So again, I would not consider these to be the final findings of our focus groups, and know that this is really just a summary to give you a sneak peek. But we have found some some very useful and actionable feedback. So I do want to share that with you today. So first, we did hear that telehealth has filled a critical gap for cancer care services during the COVID-19 pandemic. We gave opportunity during the focus groups for individuals to share their own experiences and or what they've heard from others, and then to think more broadly. And we don't use focus groups for quantitative results, but the vast majority of our focus group participants had personal experience with telehealth and for cancer or cancer-related services. So we know that it was used and overall appreciated, although there were definitely some pros and cons that we'll talk about a little bit in just a minute. We also know that there is the critical need for additional planning and additional preparation to ensure that telehealth can be maximally beneficial in the future, and to avoid what are seen as some potential unintended consequences of telehealth if the patient voice is not considered as we move forward. So I'm going to drill down into these just a little bit on these next few slides. So first, to talk about that critical gap that's been filled. We've seen this in a few different ways. We heard about this in a few different ways. So certainly, as you would expect, telehealth provided continuity for some monitoring and other types of follow-up visits that happened among our focus group participants. We definitely heard about follow-up and monitoring visits for oncology providers. And I'm using that term pretty loosely because we heard about oncologists and radiation oncologists and surgical oncologists, but also others who were involved in care related to the individual's cancer diagnosis. So endocrinologists, et cetera. We also heard quite a bit about maintaining access to mental health providers, which is the third bullet here. And that was, a theme that emerged, I think, more strongly than any other continuity aspect is how much our participants valued the fact that they could continue to work with their mental health providers using telehealth during this time. We also heard from many of our participants who actually initiated relationships and in some instances care with new cancer providers over telemedicine during the course of the pandemic. With a few of those examples, there had been an initial meeting months before, and so there was really never, met face to face, never shaken hands with, or had any other connection with their oncology provider, and the first time was over telehealth. And as you would imagine, generally, while that might have been acceptable or might be acceptable during our current pandemic, that was definitely not considered a best use of telehealth moving forward. And one of the other things we learned about quite a bit is how it allowed support groups to continue. And I'm using support groups pretty loosely here because we heard about a lot of different kind of venues to connect with others who had a similar situation or a similar scenario. And so in some instances, that was literally taking a support group that was meeting in person and changing it to being done remotely. And in other instances, there were groups that identified that they could begin using telehealth or these platforms during the course of the pandemic. So a lot of benefit to allowing those support groups to continue to meet. And again, this is just very high level, but lays out what some of those pros and cons are that we heard about telehealth use, again, as filling that gap during the pandemic so that we can learn from that as we move forward. So of course, on the pro side is safety. And specifically here, I mean safety in terms of not exposing oneself to infection. So of course, a great appreciation for not having to travel to provider's office during the pandemic. Absolutely convenience, and that's something that we hear as a rationale for telehealth pretty consistently. You don't have to travel, you have less time waiting typically, although we heard different things about that, especially during the learning curve period, but typically less time waiting, less time away from work and family, lower costs, the ability to include family and caregivers, and that's actually something that we'll talk about quite a bit when we have the final themes from this, was that especially during the restrictions, during the time of the pandemic, if you went in to see a provider, you were limited, either prohibited or limited in terms of the number of people who could come with you. And telehealth allowed you to continue to engage the caregivers you wanted to be engaged in your care. And then we heard from some that providers seem to have more time and less distractions. And again, this is in the context of the past few months and in the context of the pandemic. But if you go to the con side, you'll also see that we heard from almost just as strongly and just as loud that providers seem to have less time and more distractions. So that seemed to have been very dependent on the provider, him or herself. Other cons had to do with technology barriers, and I think that's an obvious one. Patient and provider learning curves. We certainly heard quite a bit on both sides, and I expect from providers we'll hear quite a bit from them about some of the challenges that they faced in learning the technology. We heard quite a bit about privacy concerns, and some of that had to do with the platforms themselves. I think there have been stories certainly about Zoom being hacked, but also who's in the room with you, and are you, some people just aren't able to go to a private space, maybe away from their kids or other people in their family, or you can imagine different scenarios to have a focused private conversation with their providers. We also heard quite a bit about anxiety related to telehealth visits. And some of that had to do with using the tech, physically or being able to get to the point where they're having that video conference or the phone connection with their provider. So some of it had to do with just navigating the technology, but also a good deal of anxiety around the lack of the physical exam, and in some instances, patients needing to report on basic information about their health, like temperature, blood pressure, et cetera. But there was concern that there might be clues that were being missed or misdiagnoses because of the use of telehealth. And not surprisingly at all, reduced feelings of connection. So that, especially if you didn't already have a strong relationship, that much less feeling of connection with the person who you're seeing on screen instead of being in the same room with him or her. And then finally, we heard so much about how these patients were really very accustomed to dealing with a care team. And I think that's, something that we've all really encouraged and we all really want to see in any sort of cancer treatment situation. It's a team sport. And now we're in this situation where, using telehealth, the vast majority of the people who had those services only were speaking with their oncologist or sometimes a NP or a PA, which is good, absolutely, but they really felt like they were missing out both physically and for their physical and emotional health on having connection to more individuals on the care team. And we heard about a lot of people, but nurses especially. So let's switch gear and talk about how we may be able to inform additional planning for telehealth in the future to make it most acceptable for providing cancer-related services. So the first thing is to have not just patients, but that we also heard from our focus group participants that they want to see providers being much more thoughtful and proactive as we emerge from the pandemic about what types of visits related to cancer care, survivorship care are appropriate for telehealth. So to think about, maybe a continuum, and there's one little example that's a little hard to read, but it's provided here on the slide. There's really the thought that there's a continuum, and so we'll flesh this out more when we go through the details of the focus groups. But along this continuum, if you start on the left, which is least appropriate, that first visit with a provider who you don't know. The next one talks about if you're symptomatic, so you're having some sort of symptoms and you're concerned that they're related to recurrence or regression, and so forth and so on. Where you get to the right, where you're having more of kind of those monitoring of oral treatments or routine follow-ups that did feel much more acceptable and sometimes preferable to have via telehealth. So our participants really wanted to know that their oncology providers were being proactive about identifying which types of visits they thought were most appropriate, and that we can also absolutely inform the patient perspective here. So other things that they wanted them to think about was that first, clear strategies are needed to ensure that telehealth is going to promote access to care and not exacerbate disparities. And I think that there's a lot of concern about this more globally when we think about telehealth, but certainly, we heard about lots of individuals for whatever reason who may not have the hardware, the software, the Wi-Fi access, et cetera, and that there needed to really be creative solutions to ensure that if telehealth was available, that anyone who wanted to participate would have the ability to do that. Certainly that providers need to have much more training and familiarity. We heard lots and lots of stories about providers who didn't know or used their platforms incorrectly, and this in a health visit type situation. We heard about things like patients who inadvertently came into the room at the same time. So clearly those are concerns, and the providers we're scrambling, of course, during the pandemic, but moving forward, they need to really be much better trained and really know how to work the technology and how to have an effective telehealth visit, because it is different, and we will have some specific thoughts about how that communication can be better via telehealth. Certainly, providers need to better prepare patients and their caregivers for their appointments. And we got a lot of great suggestions, pulling some best practices that had been used across our focus group participants and then thinking about others. But many of the individuals we spoke with had very little preparation to have these appointments and to thus have a successful interaction. We learned that, especially in the context of telemedicine, the technology, other services that can be provided around it are really, really critical. And patient portals is one that came up a lot, to be able to access results of labs or scans or what have you, and to be able to do electronic communication with members of the care team. And that's, I think, widely recognized to be important across the board, but our participants felt that if you're going to have telehealth, telemedicine visits, especially critical to have those additional components. And then we heard quite a bit about cost, and we know that we heard a very strong recognition from our focus group participants about some of the changes that had happened on the physician side, and understanding that physicians and providers do need to be paid, they need to be reimbursed for telehealth services, but that patients were finding the patient responsibility, the copay, the out-of-pocket to be unpredictable, and sometimes there was some question about whether you should pay less, you should pay more, you should pay the same for telehealth as opposed to in-person. So we'll tease some of that out as well in our final report. And then to kind of summarize where I think we'll spend a lot of time as we describe the output of this project, there was a feeling that telehealth should absolutely in the future be offered and covered to replace some cancer-related care, and most critically, this should be based on patient preference. So we already talked about this feeling that providers needed to identify the visit types they thought were most appropriate to be able to offer, a menu of options to their patients. But absolutely every focus group, many times we heard individuals say, so you can have that kind of menu of options, but some patients don't ever want to interact with their provider on telehealth, and they should never have to. And some people, may feel very comfortable in visits where, for instance, they are having a scan read where there could be bad news, but they may feel much more comfortable with the prospect of hearing that bad news while they're at home with their family around them, while others really would want to hear that only in a face-to-face sort of discussion with their provider. So while a menu should be offered and we should continue to take advantage of all the benefits of telehealth, it should always be patient preference about whether it's telehealth or not. Now, again, right now, in the context of still being in the time of a pandemic, that's a little bit different. We're thinking about when we get out of the pandemic time. There also was huge interest and support for having telehealth that could engage multiple care team members. So again, not only the oncologist and their NPs and PAs, but also nurses. Again, we heard a lot about the nursing staff, social workers, navigators, psychologists, others who are there if you're physically present, are part of that care team, but often are not individuals that you interact with if you are participating in services using telehealth. And then quite a lot of thought about the timing and availability of services related to your cancer care. So tests and scans came up all the time, and there needs to be sequencing and very thoughtful timing of those so that if you have a blood draw or a PET scan or what have you, that those results are available at the time of your telehealth visit. And for many of our participants, they really wanted the ability to see those ahead of time, again, in patient portals before having the telehealth visit. So that's thinking about replacing. So how can we take these good things that have come out and continue to benefit from them as a replacement for what could otherwise be a face-to-face in-person meeting? But then we also talked quite a bit with our groups about how telehealth could be a mechanism to actually improve care. So to remove some barriers to care and to actually really catalyze innovation in cancer care. And many of these ways we've really been wanting to move forward. And these, will certainly be a little bit more challenging, but I think starting to envision the use in this way will really help us, to move forward. So we heard a lot about, wouldn't it be great if all of my providers could get together and plan my care together with me involved, or even before I talk to them? So why is it that, I'm repeating myself or sharing records with so many different providers when they could all get together using this mechanism to be able to plan for my care? So multidisciplinary care planning, similarly care coordination. I've got one provider who wants to change a medication and I'm not sure if my cardiologist wants to put me on something new. How does that work with my oncology treatment? And so can you get them together to do care coordination? We talked a lot about second and even third opinions being done via telehealth, especially across state lines. And so can we not only maintain, but really expand the ability to get second opinions? Similarly, for clinical trial recruitment and monitoring, there were a few individuals who had those experiences and actually really found them very, very, very good uses of telehealth. And so we know that we really want to open clinical trial participation to more individuals, and specifically to individuals who, may be disproportionately sheltered from those opportunities. So can we use telehealth to really enhance clinical trial participation? Certainly for supportive care services and support groups. So there were very creative ideas about having the ability to meet with navigators or meet with social workers to do even group sessions to hear about what to expect with your cancer treatment, and about what to expect as you move into survivorship, about the use of palliative care. So a lot of really very interesting ideas came up about how telehealth could really make it much more feasible to access some of support and related services that might be challenging just in terms of time or your laser focus on treatment when you're in the treatment phase, but it might really help increase uptake of use of these services and certainly help patients have a better and more holistic experience. So these, again, are things that we'll continue to expand upon as we fully evaluate our options, or fully evaluate our themes. Okay, so next steps, again, we're completing the focus group theme development. So that's happening as we speak. And the steering committee will review and revise, and that'll start this week. We are keeping this project on a very fast timeline. So we will have the steering committee review, rapid, and get any revisions in place that's needed. Go ahead and reach out to cancer providers. That'll be in the next few weeks as well, and keeping it pretty quick, and then move into actually developing the products, the toolkits, and policy recommendations. And then my colleagues at NCCS will do their policy advocacy work to bring these ideas forward. So then finally, I just want to recognize the many people who have been instrumental in moving this very fast and very interesting project forward. You can see here the members of our steering committee who, again, volunteered, literally many of them overnight or within the course of a few hours, to take this work on, and who have just been amazingly responsive and successful in identifying focus group participants, helping us refine the concept for the focus groups. You can also see listed here the project team. So Shelley and myself, also Elizabeth Goss and Brittany Harris. And then one final thanks to Pfizer for their funding support for the project. And with that, I will ask Shelley if she has anything to add, and turn it over to you.
Great. Thank you so much, Chris, for sharing an overview of what we're working on. I know some of our steering committee members are on right now, so thank you to all of you for your contribution to this project. We look forward to sharing more details with you this week and getting your input. I would love to open it up if anyone has any questions that they want to share. I haven't seen any questions in the chat other than whether the slides would be available, which we can make them available. But feel free to add any additional questions you may have. And Chris did a great job of sort of walking the line of like sharing with you what we've done without, we still haven't reviewed all of it with our steering committee yet, and we're meeting with them Wednesday, so we wanted to really let them have a chance to weigh in before we kind of finalize anything. But I think you have a good sense of where we're going with this and some of the input that we received from the focus group participants. The focus groups are really wonderful to listen to because there were just so many different perspectives. And even on the sixth one, people were saying things we hadn't heard before, that a new perspective on what they'd experienced. And most people on the focus groups had done at least one telehealth visit. There were a few who hadn't yet, or maybe had done telehealth for mental health services, but not necessarily for cancer care yet, but they had appointments coming up. A lot of them were still in treatment. Some were in their post-treatment survivorship phase, but it was, you think when you thought after hearing from that many people, maybe we've kind of captured all the unique different types of, points that we would need, and then people would bring up new things. So it was really great. And I'm looking forward to getting feedback from providers as well. I don't know, Chris, if you want to share anything. I know we've been monitoring a lot of different feedback from providers through some webinars that some of the professional societies have done for their providers, talking about how to implement telehealth in cancer care. And we've also asked a number of people that we've talked to on our last week in our symposium session, and then webinars that we've done for their perspectives. So we're looking forward to getting more structured feedback from the providers in the survey that we'll be sending out next week with both the themes that we heard from patients, and then some specific questions to them about what they think has worked well, what hasn't. I think there's definitely a lot of provider issues that need to be considered as well. I don't know if Chris, if you want to mention anything about what we're hearing so far from providers, even though we haven't done the survey yet.
Right. Yeah, I mean, anecdotally, definitely, Well, I'll just share some things I've heard, and certainly these, again, this is anecdotes. Heard from a few provider colleagues who are older, and they reflected, one of the things that we asked of the focus group participants is to think about populations that for whom telehealth may be more challenging, and certainly older individuals came up as a not in every instance, but as a population that we should consider when we're making sure we don't, create disparities in care. And so on the provider side, I've heard the same from many of my provider colleagues that it's, the younger oncologists or the younger providers kind of are much more familiar with the technology and just less kind of, I think, daunted by the technology. So they're having an easier time making this transition than some of the older providers who may not have previously used a lot of it in their, kind of personal social interaction or professionally. So certainly that's some feedback I've gotten. The still the ability, kind of I've heard the reassurance on the part of providers that even if if it feels like more of kind of a touch base than a clinical visit, how reassuring that is. And we heard that from the focus groups as well, but on the provider side, to be able to just check in and just make sure that their patients are doing okay, including those who have had to put their treatment on pause because of concerns around infection from COVID. So that ability just to make that connection and to ensure that the patient is doing okay has been important to them. I'm looking forward again to getting more actual data and a little bit more summary, but certainly there's a ton of use happening out there among cancer providers and others. And despite the glitches, I think that some providers are kind of grudgingly saying, well, we know it's here to stay, and others are saying, this is great, it's here to stay. We can really try to think about the best uses. But across the board, I think everyone is acknowledging that telehealth will maybe not look the same next year as it does right now, but it'll certainly be present in a way that it wasn't a year ago.
And a couple of things we heard last week from panelists in our the Future of Cancer Care panel. Dr. Ana Maria Lopez said that they'd convened a task force to help with their implementation of telehealth to make sure that they were addressing patient barriers, and even went so far as to purchase phones or tablets for patients that maybe wouldn't have had them and wouldn't have had access to telehealth otherwise. So I'm definitely going to be getting some more input from her on what other things that they did as an institution. She's at the Sidney Kimmel Cancer Center in Philadelphia, and how they really tried to address those barriers head on. I think that they were especially proactive in it, and more so than I've heard from some other practices. Also, Dr. Deb Schrag from Dana-Farber said that she really liked the ability to see into a patient's home and see their environment, because she's used to seeing the patient in her environment, not in their own, and that gave her more of a window into the patient's life that she thought was helpful to her in treating the patient. So I thought that was a really interesting insight, and I'd heard that from from someone else who said, it just gave them a little bit more information about the patient's life to try to treat them more holistically, which I think can definitely be helpful.
Yeah, along those lines. So one of the things, and again, I'm trying not to say everything else in the focus groups, but one of the other things that we heard about, and one person used the analogy, which I think is a great one, about what schools have done in terms of ensuring that they're trying as much as they can to promote, I guess not ensure, but promote equal access to online learning. So can we take some of those best practices, and those have included giving, hardware, so laptops or smartphones or whatever might be the barrier for patients to connect, ensuring Wi-Fi access and adequate, because we also heard from many people, and some of this I think was related to our specific time in history, but some people just don't have sufficient Wi-Fi bandwidth to be able to have an effective visit. And And we heard about that on the rural side and in urban settings, that sometimes you can have unique challenges in like in New York City, in very urban settings to have adequate Wi-Fi. So is that, when we start to think about even kind of social determinants of health in relation to telehealth, those things may start to feel like they're very important in healthcare investments that we may not have thought about so much in the past, if we're going to have telehealth visits be something that, as we expect, will be with us in the future.
So, Chris, we have a question from Desiree. She asked if the focus group participants shared whether they were nervous before their initial engagement and whether their healthcare providers appeared comfortable using telemedicine.
Yeah. Hey, Desiree. So we heard all about a lot of anxiety prior to these visits, and the anxiety really, or the nerves really spanned being able to actually connect, having that successful connection to the provider, but also what would a visit be like? What would that interaction be? Would it be natural? Would it seem weird? And we heard from a lot of people, and this will certainly be in the report. Heard from a lot of people about how even more than in an in-person face-to-face setting, all their questions or their issues or their concerns went right out of their head. Kind of like the stress of getting connected really made it hard to keep in mind all the things that they wanted to bring up during that provider interaction. So we certainly heard from that. And then on the provider side, also, I'd have to actually go back in the notes and make sure that I'm not kind of overstating this, but I know we heard from a few people about that some of the providers just seemed more comfortable, and I'm not sure about nerves, but certainly more comfortable than others in using the technology. And we heard from many people who talked about how different it was to see their provider in their home setting. And sometimes, they said it made me feel much closer to them, because I saw that they were human beings, and like their kids are running around the back and my kids are running around the back. And it just kind of created a different type of relationship with their provider. So that, having the more kind of humanization of the provider, him or herself, may end up being a piece of this as well.
Great. Well, there's no other questions from the audience, so we are almost 2 o'clock. So if we end a couple minutes early, I don't think anybody's going to be too upset about it. So I don't know if you have any closing comments, but I want to thank you so much for taking your time and for sharing an overview of where we are so far.
Oh, thank you. And I want to again thank the steering committee, who is the second steering committee I've had the pleasure of working with at NCCS, and a little less closely than our redefining functional status project, but another just amazing experience of very dedicated individuals who, are really just so willing to give of their own time and their expertise and their networks to help move this work forward. So thank you all again, steering committee members and the NCCS team. And every opportunity I get to work with NCCS just puts a huge smile on my face. So at this time in the world, that's always a good thing.
Chris used to mainly work with providers, and now has realized how much more fun it is to work with patients.
Absolutely. Yeah.
And that when we ask them questions, we have to listen to them, and we get great feedback and advice. So now we just have to make sure that we can get that out into the world so that other people are listening to what patients want out of this, so that we can make sure it's successful for patients and helping them to have better experiences with their cancer care. Yes. Well, thanks everybody for joining us, and thank you, Chris, and to all of our steering committee members and our project team. And we will see all of you back tomorrow at noon Eastern time for our final day of sessions. And I hope everybody has a great day. Thank you.